Okay, I think we're going to start. Thank you all again for joining us today. I know it's quite difficult circumstances for many people, so thanks ever so much for joining. This session is going to be recorded, so if you have to drop out or if you want to share it with colleagues, there'll be a link to this on the ICB website. I'm Toby Garrood. I'm a rheumatologist at Guy's and St Thomas's and the medical director for the ICB, and this is one of our currently occasional but hoping to become more regular 2020 seminars, which are here to showcase innovation and great practice in South East London, particularly with the intention of sharing good ideas which can be scaled across our system. Just a couple of points of order. Questions are welcomed and encouraged. The idea is Dagny and Mark will talk for 20 minutes or so, and then we'll have 20 minutes or more for questions. Please put your questions in the Q&A section and not the chat. So I'm really grateful to Dagny Rajasingham and Mark Hawkins for joining us today. Dagny will introduce herself, and as will Mark, but they've been working on this. It's genuinely innovative and very exciting work around data-led prioritisation. You'll all be aware of the challenges we have around capacity, particularly when managing patients with long-term conditions in the current climate of strained resources, challenges around productivity, and as you know, an expectation that we do reduce overall follow-up numbers. But most importantly is how we address patient outcomes and make sure we're maintaining outcomes, and in particular address health inequalities as we do optimise capacity in outpatients. And this is some really fantastic work which shows us how we can use data to make the best possible use of our capacity. So I'm going to hand straight over to Dagny and Mark. Thank you.
Thank you very much, Toby. Good afternoon, everyone. My name's Dagny Rajasingham. I'm Deputy Chief Medical Officer at Guy's and St Thomas's and work with Toby clinically. I'm an obstetrician by trade. Mark, would you like to introduce yourself?
Hi, good afternoon, everyone. My name's Mark Hawkins. I run Factor 50. We're a small East Midlands-based company doing healthcare analytics and digital work.
And Factor 50 and GSTT have partnered to develop this work that you're going to hear about. Next slide, please. All of you on the call, I am sure, by virtue of being at this webinar, be aware of the disparities and outcomes that we have for significant proportions of our population, especially so in certain parts of London, South East London being one of them. And what we wanted to do was to show you the case for diabetes, talk a little bit about the societal and institutional biases. We could talk for a lot longer on that. We then want to show you what data we used and how we clinically prioritised. What did we find from that exercise on a cohort of patients at GSTT? And then we'll show you some extended data. And then what sort of action we could take. And we'll show you some work from both GSTT and Sheffield Teaching Hospital. Next slide, please, Mark. So in relation to diabetes, continuous glucose monitoring is a gold standard of care now. Wherever possible, we're being asked to roll it out. And this slide just shows from 2021 data, but these disparities, differences and biases still exist today. So if you look at ethnicity and if you look at CGM data from various populations, you can see that as we get into the global majority, our use of CGM data, availability of CGM data is reduced. And likewise, when we look at deprivation, the most deprived populations have the least access to it. And this will come as no surprise to many of you. And I put this in the context of the NHS's one of four priorities, which is reduction in health inequalities and inequities. Next slide, please. This slide is showing you on the left side a graph for national data, and on the right side to our Southeast London, so our geographically appropriate data. And this looks at patients with type 1 diabetes who have an insulin pump. That's the blue bar chart. And then the red line is those who have the appropriate level of glucose, so that their CGM monitoring is appropriate. So if you look at the the pump, you can look at the left side, you can see that with the least deprived population, 14% of them are using it versus the most deprived 9%. But actually, the most deprived group are also the group who least often are reaching their targets. So if you look at the double whammy or the combined effect of this, the disproportionate effect on the populations whose care we are trying to improve and whose outcomes we're trying to improve, you can see the compounded effect. If we look at South East London, in our most deprived in terms of insulin pump usage, we're slightly better, but in terms of the disparity for data, so being within the recommended ranges for your glucose, we perform slightly poorer. Next slide, please. So the problem that Factor 50 and GSTT were trying to solve together, and this work started just as the Omicron wave hit us in our dim and distant past. You will know for a variety of reasons, including COVID, we had a significant backlog of care. We had a lot of high-risk patients sitting with long-term conditions and multiple morbidity within our waiting list, but had very little sight, clinical sight of those patients who were either running into problem or who were high risk. And this was all right when we didn't know the scale of the problem, but with COVID, with the unveiling of further disparities in healthcare, we became aware that it was an issue. It was an issue that was going to go on for some time and that we needed to start addressing it. And for many of you, the recurrent 11, 12 now periods of industrial action that we have compounded our efforts and attempts to recover, both in ambulatory care and in surgery. So what we wanted to do was to enable an efficient and effective system of risk stratifying patients so that you saw the right patient at the right time in the right clinic by the right person, without using what it was and still is that precious resource of clinical time, especially senior clinical time. Manually prioritizing these lists is impractical, inconsistent, has a lot of unwarranted variation in it, and just isn't an efficient way to do it. So data-led prioritization, which is the solution to this problem, is a digital approach that we have developed in partnership with Factor 50, with expert clinicians at GSTT, and we're going to show you the model around diabetes. So it was predominantly the diabetes consultants who helped us to deliver clinical rule sets, which we have then applied in an automated way with the necessary checks at each level, at patient level data, to decipher the risk that sits within those patients on those lists. So as an example, we have 4,500 patients on our list. We then risk stratified them into the red flagging patients, so the highest risk patients, down to the green flagging patients who were the lowest risk patients, or those who were not concerning. Please don't P1 to P4 does not relate to our risk stratification of surgery. And what we found with this system is that we could see the high risk patients, we could see them, we could identify their modifiable risks, treat those, and reduce harm. And in our patient cohort at GSTT, this was a reduction in harm of 40% within the red flaggers. And with the green patients, we could delay them being seen, we could touch base with them, but delay them being seen in a clinic, and or follow them up either by patient-initiated follow-up or by virtual appointments. I'm going to hand over to Mark to the next slide.
Perfect. Thanks, Dagny. And so what we're trying to do is we're trying to understand the patient as well as we can, and that relies on looking for information from as many sources as we can. So just that I'm clear here, we're looking at secondary care patients who are on the follow-up list, but for those secondary care patients, we're trying to find all the relevant data that we can. So we start with hospital data, that's the foundation. We need to understand and map all this to all the appointment data, and I'll show you a few views of that in a minute. But we're looking at, for diabetes patients, you won't be surprised, we're focusing on blood tests, glucose level, kidney function. We're looking at other things like, have they presented at A&E with a diabetes-related incident? We might be looking at recent diagnosis. Have they had eye problems or foot problems that are really significant, and there might be some information in the medications. We're also, like I said, trying to build that richer picture. So often there'll be blood tests happening in primary care that nobody's aware of, nobody's looking at. So we'll try and bring that data in as well. Through London, we've done that with the Discovery data set. We've sort of proven the path to that. And so if we were to work with other hospitals, other trusts in London, you guys will hopefully know Discovery is a shared data set across London and a really powerful resource for you guys to be tapping into. So in London, that's how we've accessed some of the broader data. And then for diabetes, but also rheumatology that Toby touched on, this patient-provided data is really powerful. Obviously, in the diabetes space, the CGM, so the continuous glucose monitor patches, that are maybe now being worn by a quarter of the diabetes population. It does depend, more heavily prevalent in the type 1 space. But these CGM devices are throwing off data every 5 minutes, which is really powerful, but somebody's got to be able to look at it, process it, make sense of it, and relate it to all this other information in here. In rheumatology, we're looking at PROMS data, patient-provided outcome data. Dagny?
Sorry. So what are some of the outcomes? Because the focus of this session is on tackling health inequalities, what we wanted to show you was the breakdown via ethnicity of the group of patients on our diabetes ambulatory care waiting list. So if you look on the left side at the breakdown of all patients by ethnicity cohort, you can see that the ethnic minority or the global majority group of 30%. If you look at the breakdown when we had stratified them into high-risk patients, so this is the red flagging group of patients who had some of the rule sets that were worrying us that needed to be seen sooner rather than later and who had modifiable factors, that was 45%. So just by virtue of this process of identifying the high-risk patients, we had already focused on the group that we know within diabetes as a long-term condition are at higher risk of poorer outcomes. And this is a story because whatever we do, patient outcomes from our perspective might be improved, but the important thing is that the patients are engaging, that they think that this process is also supporting them and helping them. And this is a good story about one of our patients that was taken up by the Evening Standard using this risk analysis that we had, involving the patient in their care and allowing them to access care in a more timely way. In a subsequent patient, we also got feedback that said, thank you for seeing me. I thought I'd been forgotten about. And for those of you who are helping to run services at an operational leadership level, you will know that this is a significant worry of a lot of patients who don't want to bother us because they know that we're going through difficult times, that we've got a lot of patients we're trying to get through. But that element of not being forgotten, of knowing that someone has looked at their data or the available data is really important. And as Mark iterated earlier on, we sit on a huge amount of data that we may not necessarily manually be able to look at, to screen, to analyse and to act on. Next slide, please, Mark.
And so the 4 specialties that we've been working with Guy's and St Thomas's on are diabetes, rheumatology, but then also heart failure within cardiology and renal. And the reason we focused on these 3 that you can see on the slide is, as you guys will know, the sort of interaction of these conditions is really strong with a number of patients. One might cause the other. There'll be plenty of patients with multiple morbidities in this space. And so we're working with Guys to try and create more of a single view, so a less siloed view and a more coordinated approach to the care of these patients, because very often they're coming into hospital a huge number of times. The DNA rate is very high, and it's really important that the hospital starts to think about joining up the care and the coordination of the care of these patients. When we look at the health inequalities angle on this just repeats and reinforces everything that we've already seen at a national level and at a South East London level. And so the top chart, if you can see it, the ethnic minority or global majority group who are just on one waiting list across the 3 was 38%. But when you look at patients that are appearing on more than one waiting list, that jumps dramatically from 38 to 56%. And then if you look at the poorer deprivation groups split by IMD decile, so 1 to 3, patients on just a single list is 37%, but that jumps to half of the group when you look at patients that are on more than one list. And when you talk to these patients, a lot of them are having to take time off work to come in. So all this sort of multiple interaction, high frequency of appointments isn't great for them as well, because having to take time off work, expensive visits into hospital, and we can do a much better job of coordinating their care. This was a view of patients, which will take 30 seconds for me to explain, but is hopefully powerful, was really exciting when we first saw it. So this is diabetes patients at Guy's and St. Thomas's who are on the follow-up list. There's about 4,500 of them, and this is the view that we had of these patients 2 years ago. The blue bars on the right-hand side are the dates of the next appointment for these patients. So the data was cut in February 2022. So you'll see that the next month, March, was the most popular month, and then you'll see that patients, most of them have an appointment. They all should have an appointment. So we found 620 that didn't, and that was helpful. But you can see that a number of them are not being seen for 6 months, 9 months, 12 months. Then what we were able to do was apply the risk stratification, the red-green methodology, to all of these mini cohorts. And what struck all of us, was there were nearly 250 patients hitting at least one of those red rules that weren't going to be seen for at least 3 months. A number of them weren't going to be seen for 6 or 9 months, and a number of them didn't even have an appointment. So these are triggering pretty significant rules that the consultants said, it's modifiable as well. Let's get them in. Let's do something about it. The good news was we weren't just adding stress to an already really busy system. There were almost the same number of greens, low risk, relatively stable patients that were going to be seen in the next 3 months. And so that created the start of the opportunity to use this approach to potentially defer the greens and create capacity, and then be able to pull forward a number of the reds. The exciting thing for us is that this is an approach that's starting to scale. We can take it to other trusts. We'd love to work with more trusts. This was exciting about 3 months ago, when we onboarded Sheffield and saw a very similar pattern. So roughly 1 in 5 are red and need to be seen earlier. In the case of Sheffield, we got a richer set of data, actually access to more blood information from primary care much more quickly. And I think that's partly why there's more of these blue-greens. And the blue-greens are just slightly different variants in low risk, really. The greens there's encouraging information on the patient since they were last seen by a significant review, i.e. a consultant session. The blues are the long-term stable. So we look over the last 12 to 24 months and come up with an evaluation that they're long-term stable. And so the greens and blues are really great candidates for deferring 6 or 12 months, maybe being seen by a nurse instead of a consultant, maybe PIFU'd, maybe passed back to primary care. But you get the idea. From the blues and greens, you try and create the capacity. And from the reds, you try and pull them forward. And then you also can't forget about the greys. The greys need a fair bit of oversight. You need to make sure there's guardrails in place to see the greys in a timely fashion. You'll also have noticed Lewisham and Greenwich, that is supposed to be blank. We're just onboarding LGT, really excited to be doing that. We've had the first cut of data. It looks encouraging, but I'm not yet ready to be able to sort of display this. But we're only probably a week or two away from being able to show the split for Lewisham. Again, another slide that'll just take 2 seconds to unpack, but this is Sheffield data. And Sheffield operate a partial booking system, which is really good news for us because we can drive change much quicker with a trust that's operating in a partially booked way, because you've just got less things to change. So if a patient sees a consultant in Sheffield, because it's partial booking, they'll be told, come back in, let's say 6 months as an example, but they're not actually booked in. And so there's essentially a target date in the system for when they should be seen. And your x-axis along the bottom there is showing how many months until they're due to be seen. So if it's 2, that means they're supposed to be seen in 2 months. Anything to the left of the dotted line, therefore, means that they're overdue. And then what we're able to do is then do our normal trick of splitting all of the mini cohorts into reds, greens, blues, and greys. And so you'll probably be drawn to the same first population that we were, which was right, let's get the reds in who are overdue. And then you've got decisions to make, or the clinicians at Sheffield have got decisions to make. Where do they go next? Do they focus on the greys? Do they bring in some of the other reds? But suddenly they're informed. Without this, it's just a huge list that feels overwhelming and everyone's kind of grey. But with this, it hopefully brings it alive and they can make informed decisions. We're also able to create very efficient reviews. And so the greens and blues still need a bit of oversight from a consultant. We're only providing prompts back to the clinicians and consultants. So for the blues and greens, what we're now running is super efficient sort of review hours where a consultant can get through potentially 20 patients and in most cases confirm that it's safe to defer them, but it's just double checking, making sure that there's nothing else in the patient record that suggests they need to be seen soon. But essentially we're creating capacity with the blues and greens, and then we're reducing clinical risk with the reds and also potentially the greys. We've only got a couple of more slides to go, so hang in with us. This slide I just wanted to share. It's a new slide, but it's a really new bit of work that we're doing at Sheffield. So part of the data that we're able to process is the CGM data, the continuous glucose monitor data. So whilst we're processing, they have a similar cohort size of about 4,500 patients, similar to Guy's, but we're able to really screen all the CGM data, which is about 2,000 patients have got CGM in Sheffield, but we found the highest risk 22 patients. So rather than this huge sort of list of grey patients, we've identified the highest risk 22 patients. In particular, the clinicians there were focused on really low levels of blood glucose. For those of you that are technical in that space, it's time below range greater than 10%. But this is really significant. They really need to be seen soon. And so because we've been able to scan the data, we've identified them. They've got in touch with all 22. And within 4 weeks, we've got a third of them are back in a safe range. A third of them have improved, but they need to improve further. And a third haven't yet improved, and there's still work to do. But hopefully you can see that we can sort of, using data, we can really pluck out those patients that really need the attention and really take action in a really fast space of time. So last slide from me, and then Dagny will just close. But hopefully what you've got out of this presentation is our approach, we really believe, is using data, partnering really closely with the NHS Trust, and this sort of virtuous circle, so we can free up capacity. We can, in the case of diabetes, support things like the faster rollout of hybrid closed loop. We can reduce clinical risk, and we can create a really high-performing trust. And I think that starts to really reinforce, and we'll be powered by as many data sources as we can. So we're bringing, like I said, the primary care, secondary care, and then the medtech data where it's possible.
So thank you very, very much for your attention. So in summary, what we have done with our data-led prioritization and efforts at risk stratification is to apply the principle of proportionate universalism in a way with no unwarranted variation. So we apply the rule sets, we identify the patients who are at risk, and we enable clinicians to do the right thing for the right patients at the right time. And through doing this, we release capacity, both physical capacity in clinics and that very, very valuable resource of clinician time capacity as well. We're very open to questions. If you can't stay on for the question session, please do get in touch with us. If you'd like to talk to us about anything that we've discussed in this presentation, or if you would like to have a discussion about your service taking on data-led prioritization. Thank you very much.
Dagny, Mark, thank you so much. That's absolutely fantastic and really, really fascinating work and incredibly important. Questions started to come in. Let's encourage colleagues, please, to put your questions in the Q&A, and we'll try to get as many as possible. If I could just briefly start, just to ask where next. Are you looking for new areas to develop this, both in terms of services or providers, or are you focusing on those four at the moment? And for those of us who want to get more involved, is there any opportunity there?
Yeah, I'll start with both, but we are trying to prioritise the rollout of diabetes purely because, given the current resource restrictions, finance being one of them, It often is, it's helpful if you have identified finances. It's only a small amount of money to start implementing and rolling this out. But we are open to looking at the other areas that we've also focused on. That process of developing the rule sets is pretty time intensive. We're really keen to work on diabetes, to focus on multimorbidity, and to really transform long-term care. Mark, can I bring you in?
That's perfect. That's fine.
There you go.
Great, thank you. So a question from Nancy. Could you say a bit more about the risk factors which would prioritise somebody as P1 or red?
So they would be very dependent on the disease that we were talking about. So with diabetes and with renal or with rheumatology, they'd be slightly different. But as an example, we would use HbA1c. With the continuous glucose monitoring, we obviously would be talking about being in range, whatever that range is for that patient. And with closed hybrid loops, we have national guidance. With diabetes as a disease entity, there is so much agreed national guidance on what are good standards and what we should be trying to achieve. It is a relatively easy discussion. However, I'd just like to highlight that despite that case, when it comes to individual senior clinicians, we all see risk slightly differently. What this really helps us to do is to standardize the way in which a service across a number of clinicians sees risk.
Thank you, Dagny. There is a question around who you're liaising with for data upload at LGT. It might be an idea if the questioner contacts Mark or Dagny, or maybe Mark directly for that. Just about this question here about how to communicate with patients. So how do you manage expectations and anxiety amongst patients? So either labelling them as red or as low priority, if wants a better term.
Do you want me to take that, Dagny?
Yes, please.
Yeah, I mean, so Guy's thought long and hard about this, and so they've done a bunch of patient research, and they've also put it into practice in your space, as you know, Toby, in rheumatology. And so the research was very much focused on the greens because they're the patients that you're potentially impacting most actually by deferring them. You'll also be impacting the reds if you bring them forward and improve their conditions. But from a communication perspective, I think everyone is a bit more worried about the greens. And the feedback from the patient research, but also when you guys put it in practice in rheumatology, was really, really encouraging. So I think there were some really foundational pieces. So you need to communicate clearly with the patient. You need to tell them that a doctor's reviewed their data and let them know that the understanding is that they're doing okay, but do they think they're doing okay? And if they don't, they can get in touch. Here's a phone number, here's a mechanism to get in touch. And if they want to retain their appointment, they can. But also to explain that there's other patients of potentially greater need, and are they okay to have their appointment deferred? And the research suggested about 80 to 90% of people would be happy with it. And in rheumatology, as you know, about 80 to 98% of patients were happy with it. About 1 in 7 will still insist on coming in, which I think is totally fine. You still achieve a great capacity saving, but also you've communicated clearly with the patients.
Thank you, Mark. So I'm scrolling up for the questions here. So there's a question here about sustainability. When or if will Factor 50 hand over to the trusts, and who takes ownership and accountability, and also funding as well? How is this funded, and how do we build this into business as usual?
Yeah, let me take.
Yeah, go on.
So we've built it as a partnership with Guy's and St. Thomas's. I think we bring a certain level of expertise, so we've had to build a platform that robustly does all this scoring robustly and safely. We've had to go through all the governance of that, and a medical device. We are now a medical device level 1. So I think if it was a new trust we were talking to, we'd love to sort of engage them, get up and running. From my perspective, it's a service that we then provide on an ongoing basis for not very much is our sort of model. I think if we demonstrated it and after 12, 18 months, the trust wanted to bring it back in-house, they could. But it's taken a fair amount of investment just to get it safe and scalable and robust. And so that's what we offer. We'd happily talk to the trust about that. And if they wanted to try us for 18 months and then take it back in-house, that's totally fine.
Toby, can I just add to that you will know, and I know, and most of you who are clinicians will know that it isn't rocket science around risk stratification. We do it every day of our clinical lives. What is different is the ability and the speed at which we have been able to, in partnership with Factor 50, is to deliver on something that should be a no-brainer really for us. So we have a lot of conversations, both internally and externally, with people who say, but we could do this, we could do this. It is having that focus. It is having a team, so Mark's team, who are healthcare analysts, who can protect that data, ensure that the validity of that data and the provenance of that data, and all of those things take a long time. And within the NHS, working within one of the largest NHS providers, that was next to impossible until we started working in partnership. So that's just a slight health warning. It might not be rocket science, but actually delivering on it is what we've been able to do. The concept and the idea it isn't something that is so novel or so innovative.
Thank you. Question from Di, who is one of my senior colleagues in Lambeth, in primary care. She's asking, and you may not know this, but so it might be worth taking it offline. Do you know how many of these patients are local to Lambeth and Southwark, our local population?
I don't know.
Okay,
we can definitely have a conversation offline, but both Mark and I were keen to highlight that the tool, the data-led prioritisation, as it is at the moment, isn't currently a tool to use in primary care to prioritise within primary care. It's looking at secondary care and the interface with primary care, because obviously when we address multi-morbidity, we are hopefully reducing the number of times that patients have to access us, and by virtue of that they have to access their primary care physician.
There's two more questions from Di. I'll put them together if that's okay. One is based on the basis of what you've told us and understood around the impact of ethnicity on this. Would you include that in your risk categorisation? And the second question is, has there been exploration with the diabetes team as to why there is disparity in access to or recommendation of CGM in those patients?
I'll answer the second question first, start the first, and then Mark, I'm sure, will come in on it. So why do we have the health inequalities and inequities that we do in the NHS? If you segregate almost any data, any outcome data, any use of technology, including things like, the newest HIPs and who they go to, you will find that we have disparities. That's borne out in the data. BOLA, who's the NCD for inequalities and inequities, has a fabulous site on NHS Futures. Please do look at it. In terms of adding ethnicity, that is a really interesting question, and we are discussing it. We have to discuss it. The other thing for those of you who are involved in primary care or holistic provision of care for patients is serious mental illness. So Toby, you've been at discussions and we've talked about the difficulty of patients who have long-term conditions and a significant mental illness. That means that they may or may not access care as they should, or we don't make care as accessible to them. So those are things that we certainly will be considering. Really, really good point.
Thank you. And so the question here around, I guess, is kind of what next? And the question is, do you have an example of the surgical pathway? I think we established that you probably don't, but where is the opportunity, do you think, downstream in surgery, such as prioritising operations?
So when Mark first approached me at GSTT, actually, I made the approach at the same time to diabetes and to general surgery, because you will remember it was the Omicron wave, we'd stopped all of our elective surgery. And surgery just felt they didn't have the headspace capacity at the time to engage with the work. But if you ask me now, I think that was a lucky thing that happened, because there are various people, both NHS and non-NHS, chasing that elusive, how do we do our elective surgery? How do we categorize those patients? And that work is ongoing. So I suppose for us now, Mark, and please correct me if you're wrong, we want to nail ambulatory care. We want to nail comorbidities and long-term conditions. Mark, would you like to come in on that?
Yeah, very much so. We'll be clinically led by you guys, but I also think there's just a huge opportunity. I mean, if you just take diabetes alone, that's a huge space. If we added rheumatology, renal and heart failure, which is our focus, that starts to become pretty large. Potentially there's an opportunity in surgical side as well. What we've tended to find is fairly obvious, but the sorts of specialties that lend themselves well to this sort of approach is you kind of want a large cohort of patients. You want clinical sponsorship, because you're going to drive a little bit of change in terms of how things like booking is made. But you also ideally want some sort of numerical data, fresh data being generated. I think we, through this journey, have discovered there's a huge amount of data on patients that everyone's unaware of. So a huge number of the blood tests that we're looking at for diabetes patients haven't been requested by diabetes departments themselves. It's been requested by another department in the hospital or in primary care. So it doesn't mean that if you're thinking about your specialty area, you know that all this data exists, but the data probably does exist. But things like, if your specialty relies on things like blood tests, that's great.
Thank you. A question from Krishna, who has a leading role in our long-term conditions programme in South East London. I hope I get this right. With these principles, if you had the capacity and funding, could they be applied to community-based care?
Krishna, thank you for asking that question, and that is an obvious one. I have actually put in the chat, absolutely. So there is, what we want to do is to do the best that we can for our patients, and they don't see primary care, secondary care, and the boundaries that we sadly do. So we would be keen to see if there was a way to cross those boundaries that do exist and to provide the right service for the patient. Exploration is time and resources. So if it came with funding, no, we absolutely, Mark and I will be open to a conversation. So please do get in touch.
Thank you. Yes, here's an interesting question. Around the clinical time needed to review patients is always slightly thorny when we try and introduce new processes in managing capacity. So how much clinical time does this take? And give no idea of the sort of ratio of that to the release in capacity.
Shall I take that for Sheffield? So particularly where we're looking for clinical, if I answered your question correctly, Toby, where we're using the clinical time to review patients without them actually being present tends to be on the low risk end. And so we could talk about the blue-greens. What we're trying to achieve in Sheffield at the moment is an hour of a consultant's time, potentially an hour a month, and to try to get through 20 patients in that hour. And what we're aiming for is 15 of those 20 will release capacity. So by release capacity, I mean potentially defer 6 or 12 months, maybe being seen by a nurse, or being safely released so that they create capacity. So we think that an hour of that consultant's time could be worth 10 to 15 hours of clinic time if we can achieve that sort of number, because that's a multiplication of the number of patients that can be deferred, how many times they would have been seen, and obviously appointment length. So it's quite difficult verbally to try and explain it. Hopefully I've done an okay job. So it's on the blue-greens in Sheffield for diabetes. We think it's a proactive hour, but it saves maybe 10, 12, 14, that order of magnitude.
Thank you. I'm just, the questions seem to be shuffling themselves up. I don't think I've missed any. We have a bit more time. Nobody wants to put any more in. But I will ask one of my own, if that's okay. Because you did, two things actually. You mentioned those 22 patients from Sheffield, and I was just interested to know what we can learn from those small groups of patients around what the barriers are to accessing healthcare. And as a kind of adjunct to that, you also mentioned people being at work and so forth. To what extent do you think what you've learned we need to reconfigure outpatient clinics, particularly timings around the patient? We talk about this quite a lot internally, but it's really interesting to get your take on that.
Shall I kick off first, and then Mark will give you some detail on Sheffield? So, time off work. So the group of patients that we're focusing on, if we look at our local South East London patients, as an obstetrician, I know that group from the maternity side, many of them are on 0 hours contract. If they take time off to come to see us for an appointment, we don't see them at the correct time, their appointment's delayed, etc., etc. It has an impact. We have services, and I don't know if there are many of the clinicians who would disagree, that really suit us in terms of a 9 to 5 outpatient clinic appointment. If I had a choice and we had a team who could be recompensed and remunerated for it, I'd be running maternity clinics between 5 and 9, because that's when women have finished picking up their children, etc., all of that. So there's some really basic principles that we don't use and we don't apply. So I think, Toby, that there's all of that in terms of making sure that if they come to see us, they really need to see us, not just virtually, but see us face to face. And 2, that if they don't, we reassure them that they're okay, ensure that those pathways of communication and the safety netting is done in a way that we know they are being kept safe, that their risk and that is being managed and mitigated. And I don't think we always pay attention to that. And then there's a whole other barriers in there with anything that's like this. You worry about exclusion and digital exclusion, and can someone engage with virtual appointments, etc. But that is not just this population, that's a much wider population. Mark, do you want to elaborate a bit on the Sheffield case?
Yeah, thank you. I think it's worth probably confessing, when we rolled out at Sheffield, we were able to onboard them in 3 months, which is our goal. So we can take this to a new trust in 3 months. We've demonstrated that. But as we onboarded the CGM data, we were expecting just to put it into our normal sort of 5 buckets that we've shown you, from red down to blue and green. When we were interrogating the data and just doing a bunch of safety checks on the data, it's then that we discovered these outliers. And we didn't know if the quality of the CGM data was right, but these 22 patients just struck us as, almost super reds. And we're not clinically trained, but in a quick conversation with the clinicians, you could get a sense of, something's really not right with these 22. So it's not part of our sort of standard platform, but the safety checks and the interrogation of data was, and that's where we found these 22. So rather than just sort of surface them in the natural sort of weekly refreshes that we do, we pulled out those 22 straight away. And the great thing, Sheffield were able to just jump on it, put the 22 in a special queue, get in touch with them. And like I said, we've had good results in a matter of weeks.
That's brilliant. Thank you. We seem to provoke more questions. I hope you're okay to hang on a little bit longer.
Of course.
So building on the discussion we just had around the barriers to access, there's a question around barriers to accessing medicines. And is there any sort of deeper understanding we've learned from this with regards to the accessing the treatment or the medicines themselves?
Yeah. So one of the things, Toby, that I think has resulted in the success that we have had with Factor 50 and data-led prioritisation is that we haven't tried to do everything with one tool, one innovation. So we have not explored the other reasons. What we've done is that the pure aim of this was to risk stratify the patients. There is ongoing work, I know, by the national team on pharmacy, access to medicines and polypharmacy. I don't know the details of that, but I'm sure you can find it. And I know there's South East England regional work ongoing with that as well. So just to be clear that this was very much a tool to enable us to stratify in a standardized way. But for the questions around inequalities, there is on the government website, the Inclusion Health Group. There are 7 things that you can do for any group of patients where you think there may be patients who are excluded for a variety of reasons. It's an excellent website. It focuses on some really good case studies. There's one on mental illness, but please do have a look, because Inclusion Health Groups is particularly relatable to diabetes as well.
So I was just writing that down. A really great question from Alexandra, a GP colleague. You talked about the 4 specialists, in particular 3 overlapping specialties. what is there being work being done in parallel to look at how you align clinic appointments? And also I'd like to add to that, and to what extent might these algorithms, these rules actually incorporate multiple conditions?
So if I can use a live example, and just to be clear at the moment, because we've used EPIC, we're not at the moment at GSTT continuing this work, but the cardiologist and the diabetologist, so Janica was the prime academic diabetologist who supported us with this work, and we had a cardiologist who has an interest in heart failure. And what happened with the risk prioritization is that the cardiologist had view of the risk prioritization of a patient that she was seeing who also had cardiac failure. Through that red flagging and through a communication means of saying, oh, this person just needs such and such and such, please contact the diabetes nurse specialist. She could do that at the same appointment where the patient was there. As she ordered his bloods for cardiac failure, she could order what the nurse specialist wanted for diabetes. The patient could go and see the nurse specialist for diabetes, get what was done. That is first evolution of this. Ultimately, what I see in terms of, in the future is that each of those specialties will have its own dashboard so they can risk stratify for their condition. But there would be a integrated dashboard for the risk of that patient. So whoever was seeing that patient could ensure that the highest red patients were being seen appropriately or had advice from those specialists. I mean, even within our setting, Toby, within secondary care, it takes a lot of time for me to see a woman who has rheumatology, is pregnant, phone you up, make sure I've got you, get the advice that I need from you. So any form of automating, I think, will definitely help. Mark, would you like to come in on the multimorbidity?
I think you've answered it. Great. Yeah, we're trying to look at the individual specialties, but then join it up and then try and figure out which is almost the dominant specialty. So which one is the most important appointment? As you say, the EPIC work slowed down some of the progress, but yeah, you answered it well, I think.
And Toby, if I could just also say that within that, someone alluded to the clinical time. So you may have rule sets, you have diabetes, you have national guidance, and you'd think it'd be quite easy for a group of 12 consultants to agree on the rule sets, but we all see risk. So we went through a huge validation process. So I think it would still, to then get different specialty consultants to agree on an integrated dashboard would need a little bit of facilitation and work. So I would see still as a core bit of this being the risk identification rule sets for each of those diseases. But us understanding multimorbidity in its entirety, of which there are experts here, Krishna, our GP, our primary care colleagues are experts at managing this. So taking some advice from that, using those insights to then make sure that we had the best integrated dashboard that we can.
Thank you. I think we'll go on to the final question. It's a little bit involved, so I will read it out if that's okay. And some of this I think is out of scope, but you might just pick up elements. But really, it's about how do we optimize processes around all this. How do you optimize pre-clinic results, HbA1c, urine ACR, etc., prior to the appointment? Have you managed to address behavioural issues such as compliance and adherence to diets? Have you managed to provide a digital personalised care plan that patients might be able to access through MyChart? And then finally, are you monitoring outcomes such as how patients move from red risk to green and vice versa?
So yes to the last question, and I'm going to hand over to Mark in a second. The second and the third question, no. And again, I come back to scope creep with this work. It wasn't within the scope. So although it's important stuff, we weren't doing it. And the first question, Toby, I forgot. What was the...
It was just about optimizing pre-clinic results, HbA1c.
Yeah. I suppose if it is optimization of the actual result as opposed to optimization of having those results in a way that the patient knows what the results are and the clinician so they can have the appropriate conversation. Optimization of patient results, that's part of the red flagging, because if someone is red flagging, they're going to see a clinician earlier than they would otherwise in order to modify that factor. So that the key bit to the rule sets is of those red flagging patients, they have modifiable risk factors that we can impact on if we see them in a timely manner. And that last question, Mark, I don't know if you want to.
I think what I'd add is that this isn't just a case of squirting a bit of insight back to a trust or back to a clinician, because nobody's going to do anything with that. So there is a change agenda with this. We need to bring departments with us. We need to bring people with us. We've spent a lot of time at Guy's, but already a lot of time at Sheffield and at Lewisham engaging the admin population, because they are often the key people here. Sorry to put everyone else a bit below them, but the admins are often the ones making all the bookings, running the booking systems, trying to actually figure out when to see patients. And so that sort of process reinvention, we get quite excited about whether it's a full booking system or a partial booking system, which seems nuanced, but it can make a big difference about how quickly we can drive that change. And so we've only got a small team, but we will aim to support the departments we're working with, and that's at a people level and particularly an admin level, and getting into the detail of how do you set up the right access plans or whatever it is to make sure the right patients are seen.
Wonderful. Mark and Dagny, thank you so much. That was really, really fantastic, really, really fascinating stuff, and great to hear about it. And we're really looking forward to, living it in rheumatology, but also seeing how it evolves elsewhere. Thank you everyone for attending. The contact details of Mark and Dagny are in the chat in the Q&A section if you'd like to follow anything up, and this recording will be signposted on the ICB website. And I look forward to hopefully seeing many of you back at the next event. But again, thank you ever so much to our presenters. Thank you.
Thank you, Toby. Thanks, everybody.
Thank you, everyone. Bye.